Good afternoon, everybody, and thank you for letting me go first because of the flight that I have to catch. So I'm going to talk about immunosuppression in corneal diseases. It ain't a scare. So I'd like to thank Somshila because she gave all these titles or rhyming headings, so it was kind of nice. So when you look at immunosuppression, we think of the corticosteroids, which is some of the most common drugs that we've used, and the others would be antimetabolites, the T-cell inhibitors, alkylating agents, and biological agents. And as ophthalmologists, we're usually not very well versed with all of these drugs, so there's a little apprehension with wanting to start them, particularly when you come across certain eye conditions where these are needed. So I'm just going to run through, what are the prerequisites that we have to think of. I think first of all, it's very important to rule out an active infection like tuberculosis or fungus before we start these medications, and get some basic blood investigations done. Then we need to follow up these patients, so we need to do a routine investigations when we follow them up. It's very important to know that the patient is not pregnant at the time of receiving the drugs, and some of the safe drugs that can be used are drugs like infliximab and adalimumab. It's also important to ensure that the patients don't receive any live vaccines while they're on therapy, and watch out for any illnesses, infection or fever in the course of follow-up. So when we look at corticosteroids, because we usually start therapy with corticosteroids because other immunological agents, they take some time to kick in. So we usually start them in the dose of about 1 milligram per kilogram body weight, and that is tapered weekly to a level of about 5 to 10 milligrams per kilogram body weight. But then if we need to continue these drugs for a longer period of time, keeping in mind the long list of side effects which you can see on the right hand of the slide, it makes more sense if we add the other agents and taper the systemic corticosteroids and then continue on those. Sometimes for certain conditions, and I'll come to those in the next couple of slides, we tend to give pulse doses of methylprednisolone, either 500 grams or 1 gram for 1 day, and there are certain instances where we may just give it for a day, and there are instances where we give it for 3 days and then switch to oral therapy. So the list of complications or side effects associated with systemic steroids is very long, and we're all very familiar with this, and that is part of the reason why we are very hesitant to start these drugs. But for certain conditions, and I'll talk about those in a bit, it's important. The other drugs that we use are the antimetabolites, which inhibit nucleic acid synthesis, and they affect cell proliferation. So some of these drugs are, the short forms are AZT for azathioprine, methotrexate for which is MTX, and MMF, which is mycophenolate mofetil. So all these drugs help us in bringing down the inflammation, and they act either on the purine analogs like azathioprine, the dose being 1 to 3 milligrams per kilogram per day, but they help us in controlling the inflammation. Now, what we need to be aware of, particularly when we are treating patients with azathioprine, is that they do tend to have GI intolerance, bone marrow suppression, and hepatotoxicity. So it's important to investigate them at regular intervals. Initially, we prefer weekly, and then after that, it's monthly investigations on a regular basis. And if you have serial investigations, so you should actually keep a track of it, because you look at the white blood count and you notice, okay, they started with 11,000, but then over the course of time, if that white blood count is dropping and it comes down to 4,000, even though it's within the normal range, but it has dropped, and that's what we have to watch out for, that they should not develop bone marrow suppression and go into other complications because of that. So with methotrexate, we have to give it on Sundays. We usually start with 7.5, increase it. Usually we tend to give about 12.5 milligrams per week. We can go up to 20. But suppose a patient requires more than 20 milligrams for controlling of the inflammation, we should switch to subcutaneous because the bioavailability of the drug when given orally is much less, doesn't get absorbed well. So we should keep that in mind when dealing with methotrexate. The side effects I listed on the side here. Now, the alkylating agents are a little more toxic, specifically cyclophosphamide, mainly because it tends to cause hemorrhagic cystitis, so it's important for the patients to be very well hydrated. We do give patients oral drugs, but then what is found is that the IV drug, if you give it in pulse doses, is less toxic, and that's what is beneficial to patients. You can give them 3 weekly or monthly doses of pulse dose of cyclophosphamide when there's a significant amount of inflammation, and it can help in reducing the inflammation in these patients. But we have to pay attention to opportunistic infections, the bone marrow suppression, which is again because of cumulative dose of the oral drug. So what happens is, over time, the drug builds up in the body, it's metabolized in the liver, it causes bone marrow suppression, and this actually is reversible. So this can be reversed if we stop the drug in time, if we pick it up. So the other drug that we could give is chlorambucil, and in the high dose it can be given around 2 milligrams per day. In the low dose, if you have to give it for a longer period of time, it's about 0.1 to 0.2. The advantage that chlorambucil has over cyclophosphamide is the fact that it doesn't have the bladder problem, so otherwise the side effects are very similar. There are several other biologic agents that we use, which are the TNF alpha inhibitors, and all these drugs are listed out here. We usually, prescribe these medications in conjunction with the rheumatologist. But the problem with these drugs is that there's a risk of infusion reactions and infection, and it's very important to keep a watch for this. So the symptoms that patients complain of when they come in follow-up have to be inquired into whether they have any problem, running any fever, or urinary tract infection, respiratory tract infection, because they're prone for these. Moving on now. So this young lady, she was 43 years old when she presented to us, came to us with a history of dryness. She was just 43, bear that in mind. And when we stained, she had a very bad ocular surface. When we retracted the lids, this is what we found. So there's a subconjunctival shortening of the fornix. There's some fibrosis that you can appreciate here. There's very subtle subconjunctival fibrosis in this area here. And so we diagnosed her as OCP. We got a biopsy done, but then our sample had to be sent to Hyderabad because I was in Vizag at the time. And that did not show any staining on immunofluorescence. But that did not deter us from starting immunosuppression. So we referred her to the rheumatologist. He put her on azathioprine. This is time up for. This is like 5 minutes or 10 minutes? 10. Hello, 10. Okay. 7 or 10? It was 10. Thank you. Right? 4 more minutes. Okay. So she was put on azathioprine and then came to us about 5 months down the line with this kind of a picture. So we were thinking that though the eye was not significantly inflamed, but then she was very, very symptomatic, and we felt that the immunosuppression was inadequate. We did tarsorraphies, we put autologous serum, put a bandage contact lens, and sent her back to the rheumatologist for increasing her immunosuppression. So he started initially with rituximab. That didn't help. He put her on etanercept. That didn't help. Finally, she was put on pulse doses of cyclophosphamide, and that finally helped to bring down the inflammation. And the vision when she presented was 20/40 each eye. Here it was around 20/60 and CF 1 meter. And she's 43 years old, not able to manage her day-to-day activities in the house. She developed cataract because of corticosteroids. But finally, we did cataract surgery. She's been on maintenance dose of immunosuppression ever since, not had a flare-up. With closed lenses, she's now 20/30 in each eye. So we were able to salvage this only because of our timely intervention with immunosuppression. We have patients who present to us like this, 60-year-old lady, post-cataract surgery, presented to us with inability to open her eyes, watering and burning sensation. Looking at straight gaze didn't seem so bad, but when she looked down, you notice that she has got necrotizing scleritis with inflammation, with PUK. So she complained of joint pains. When we investigated, her rheumatoid factor was 910, but hemoglobin was 6. So with a hemoglobin of 6, the rheumatologist was not willing to start her on immunosuppression. We had to tackle her with Predmet. Fortunately, she did okay, and the inflammation was under control, and her vision improved. So sometimes the investigations that we do, they don't allow us to start the immunosuppression that we want. And we were able to manage her just on Predmet. We started with 8 milligrams and gradually taped it off, and she's doing better. So we may wonder whether she would need a scleral patch graft, but fortunately, it wasn't the case. We shouldn't get scared when we see this kind of inflammation, because once the immunosuppression kicks in, the inflammation comes down and they don't actually perforate. They actually heal over, they epithelialize, and then you don't have to do anything. So this remained quiescent for many years. This lady, she was 35 when she presented to us, came to us with significant inflammation, diagnosed case of SLE, and she was already on, if I remember correctly, she had received 2 doses of rituximab and that was it. But then she came with a flare-up of scleritis along with a keratitis. There wasn't an ulceration, but it was just osteostromal cellular infiltrate. And one of the fellows thought that this was an infection, so they scraped. But that was not necessary because there was no epithelial breakdown. We started on topical steroids, got her back onto immunosuppression, put her on cyclophosphamide. Now she received pulse doses every 3 weeks. And over a couple of days, along with the topical steroids and this increased therapy, we noticed that she quietened down. And after that, she's been kept on a higher dose of immunosuppression. They stepped up her doses, switched her back onto methotrexate, and now she's kind of on a 10 milligram dose and she's doing good. The other condition that we come across very frequently is Murren's ulcer, where we follow a step ladder pattern. And it's mostly the bilateral cases with more than 2 quadrants of involvement that require some form of systemic immunosuppression. Otherwise, we could get away with just topical steroids, conjunctival resection, and UBCL. So this is one of those cases which just requires topical steroids and conjunctival resection, UBCL. The bilateral cases where they have more than 2 quadrants of involvement with thinning, we would start with oral steroids. But then if you have patients like this, where there's significant amount of thinning and melting, more than 2 quadrants involvement, maybe with the perforation that's going to have impending or already happened, we would hit them with IV methylprednisolone, put them on immunosuppression like oral steroids, and then if it's a recurrent case, then we switch immunosuppression, keep them on a longer dose of either methotrexate or azathioprine. One-eye patients particularly, those are the tough ones to manage, and when they've already had a melt in one eye and they're monocular, they require IV methylprednisolone, maybe even IV cyclophosphamide to bring them under control. The other condition which we don't explore too frequently is the high-risk grafts, and these would be the grafts that are very prone to rejection, multiple grafts that have been done, deep vascularization, multiple quadrants, very large grafts which are limbus to limbus and require a repeat surgery, or if you've done a surgery in a hot eye, then and multiple grafts thereafter, they've had corneal melts following HSV, then probably they might require systemic immunosuppression. So this was one patient who had already had 2 grafts prior, and she was one-eyed, so we wanted to ensure there was scarring, so she was not amenable to a DSET. And with mycophenolate mofetil, we maintained her graft for over 3 years. Then she got careless and had problems. The other would be these kind of grafts where you have allograft rejection, where they require a pulse dose of methylprednisolone to maintain them. So this is just 1 dose, 500 milligrams, increase the dose of topical steroids, and this stromal rejection can be reversed and you can do well. So it's important to have a knowledge of the types of drugs available, their dosage and their side effects. They're very effective in all the immunological diseases that we come across, but it's important to have a regular follow-up, investigate them at each time, and work in consultation with the rheumatologist so that you can achieve stabilization of their ocular conditions. Thank you very much.